Good evening, everybody. So the title of my talk today is critical illness and programmed cell death. So I will first talk about the sepsis, which is a very common critical illness. It's a leading cause of death in the ICU, as we know. And by definition, the sepsis is a systemic host response to infection with multiple organ dysfunction. There are many patients all over the world, and the mortality rate is still high, especially in the developing countries. And there's still lack of effective therapy to septic patients. So here's the one example of septic shock, which is my own patients. This is a leukemia patient, 25-year-old female, diagnosed with acute lymphoblastic anemia, 10 days after her second time of chemotherapy, and she developed a neutropenia, as you know, that we give chemotherapy. And then she had a fever in the midnight and went through the episode of septic shock. High fever, she went through the high fever, hypovolemic shock, renal failure, respiratory failure, and basically we can conclude, and the episode of the sepsis is septic shock is infection, immune response, multiple organ dysfunction, and fortunately, and we save her in the ICU, and now the patient is still alive. So how do you host the immune response cause death in the sepsis? So this is a very old question. People will thought this should be immune response, inflammation. Everybody talk about inflammation, even in our guideline, in our textbook, the infection cause, the immune response, including cytokine and chemokine production. And those cytokine, chemokine, when they become excessive, they cause multiple organ mods and death. However, there's a multiple clinical trial to try to neutralize those cytokine and chemokines, cytokine, especially like tumor necrosis effect, and those clinical trials all fail to prove that neutralize those cytokine or blocking the TLR4 signaling will brought benefits to patients. So some of our doctor even says inflammation doesn't kill patients. For example, is Dushman, the Dr. Dushman would say. So if the immune response doesn't kill patients, what kind of, if inflammation doesn't kill patients, what kind of immune response actually is lethal? So back in the 2012, our group, I and my dear mentor Kevin, together we published a paper that we found that a protein can be activated by bacteria, especially the E. coli, and this activation will lead to the release of a high mobility group protein 1, HMGB1. And the HMGB1 is important as if we neutralize antibody to neutralize those mediator, we can save a lot of mice in the experimental sepsis. And if you use a genetic model, we delete the PKR gene, which we can reduce the HMGB1 release. We can also see significantly improve the survival during this experimental sepsis. This is a monoclonal antibody. So they developed, we can say, this dose-dependent response. If you raise the dose of the neutralized antibody against HMGB1, you can see significantly improved survival in this murine model of sepsis. So to summarize, if we use inhibit PKR or use neutralized antibody, you can protect the mice from sepsis. So the question is how? This paper, everybody is studying the HMGB1, but very few people actually know how it works. So when so our group in recent year, the aim of one of our goal is to solve the question how the molecule works in sepsis. We found LPS have another receptor in the cytosol. The TLR4 receptor is the first identified LPS receptor, which Bruce get Nobel Prize for it. In the meantime, in the field, scientists discovered there's a second receptor for LPS, which inside the cytosol, and this protein called caspase 11. when engaged LPS, it can activate Gas7D, its substrate, and Gas7D, when cleaved by the caspase 11, can form a nanopore on the membrane, on the cytoplasmic membrane, and this cause cell death, lytic cell death. It's basically like a necrosis. But the question is how LPS cytosol to activate caspase 11. That's we call endotoxemia, we call sepsis. The LPS should in the extracellular space, should in the circulation. The LPS, a big molecule, can translocate into the cytosol is unknown for many years. So we found a very interesting phenomenon that's the HMGB1 bind LPS in vitro and also in vivo. So we made a hypothesis that the HMGB1 might be the vehicle that LPS into the cytosol and there activates caspase 11 and into the pyroptosis, necrotic cell death. And this somehow linked to the the multiple organ failure and even so we spent like 3 and 4 years to finish this project, and we published a paper by our group, the endotoxin delivery protein HMG1. This is how we name this protein. So this is by function, the endotoxic delivery protein, mediates caspase 11 dependent lethality in sepsis. So this answers the question: if the inflammation, if the cytokine doesn't kill patients, maybe the HMGBN driven pyroptosis, the cell death, actually cause our multiple organ failure. So we spend a lot of time and doing a lot of in vivo and in vitro experiments and prove a pathway in our body. If we experience, or the mice experience, the endotoxemia, the liver, this organ is very special. It's also immune organ. The hepatocytes, they express the TLR4 receptor, can recognize circulating LPS. So once recognize LPS, it can release abundant HMG1 into the circulation. So the HMGB1, once outside the cell in the circulation, they bind LPS and carry LPS into the cytosol of a macrophage, monocyte, endothelial cell, and even epithelial cell, because they all express the RAGE receptor. RAGE receptor is the receptor for HMGB1. So the HMGB1 mediates LPS into the endosome, and then in the acidic environments, the HMGB1 has a special capacity that can kill, it can broken the lysosome, it can destabilize in the membrane of the lysosome. So the LPS will link into the cytosol, and there the LPS activates caspase 11. This is how it works in our body. And we also choose another neural model, which is very like a sepsis. We call this graft versus host disease, GVHD. This is especially for the hematologist. We do a lot of this, the transplantation, bone marrow transplantation a lot, especially energenic. So some patients actually will experience the GVHD. Once it's very severe, it can also be fatal. So we can see the systemic inflammation and the coagulopathy, and also some multiple organ injury. In this model, whether it's in the human or both in the human and a mirror model, the human is not the model, but it's actually our patients who have done the bone marrow transplantation. So we can see the HMG1 level goes up, the LPS level goes up in patients and mice. So in the mice, we knock out caspase 11, see what happened, and we can see significance improved in survival, and also reduced organ injury in the liver, in small intestine, large intestine, and even in liver. So we use two model. One is a murine septic model. The other is a septic-like model, GVHD model. We prove that the hepatocytes release the HMGB1 is very important to function as a vehicle that carry LPS into the cytosol through its receptor RAGE, and then kill a lot of endothelial cells, epithelial cells, and monocytes, and this can cause multiple organ dysfunction and even death. So the next question is how the pyroptosis, programmed cell death caused by caspase 11, linked to the real death, the death of the host. So let's look at the one data. This data is from a group published by Europe groups. That's so the currents of DIC, disseminated intravascular coagulopathy coagulation, the DIC, significant or markedly increased mortality in sepsis. If the patients have no coagulopathy, which the DIC score is 0, we can see that the 28-day mortality is very, very, very low. But with the DIC score increasing, especially when we reach 5, which the patient can be diagnosed as a DIC, the mortality will goes to the 70%. So it's very high, actually very high. So the disseminated intravascular coagulation, some people make a joke, should say it should be translated into the death is coming, because once it's happened, the patients have very bad outcomes. And the reason is very simple. So just took a look at the tissue. If there's a lot of fibrin deposition in our vessels, that can induce our microcirculatory failure. So once it's severe, of course, the organ, the tissue, they have a hypoxia, very prolonged to have hypoxia, so they can lose their function. So it promotes organ dysfunction and death. So we look at our data. The extracellular HMG1 is critical for the caspase-11 dependence, the lethality in sepsis. This is our finding. And we also combine what other people found. This a Japanese group published a paper in the TH in 2005. They found the serum HMG1 level are correlated with the DIC score in septic patients. So when we put these things together, we come up with a hypothesis. The HMG1 caspase-11 signaling might mediate DIC in sepsis. This is a mystery. We don't know how the sepsis causes DIC. We only know that tissue effect is important, but we don't know what activates the tissue effect causing DIC. Is this caspase-11 gastromin D is substrate? Yes. We spent 2 years. We proved this hypothesis. We published a paper in Immunity, and the title is "The Bacteria in the Toxin Activates Coagulation Cascade Through Gastromin D." Gastromin D, the substrate of caspase-11, and this leading to the lethal host response. So just look at the figure. We use the in vivo imaging skills. We can visualize the DIC. The thrombin, once the thrombin activates, it can cleave this one substrate. This substrate is a probe. We use the probe. Once it's been cleaved specifically by thrombin, it can create green signal, fluorescent signal. So you can see green, that means thrombin activation. If you use the blue dots, plates aggregate, we mark the platelets with a blue signal, fluorescence signal. Once you see a lot of the blue signal deposition in the circulation, that means the platelet aggregation. And also in the purple means fibrin. The fibrin deposition means the last step of a coagulation. And you also see the microcirculation. We monitor albumin. Albumin is with red. If there's a DIC, there's a fibrin deposition in the vessels. That's you can see that's the blood, the circulation is blocked. So you can see caspase-11 knockouts. If you give the same dose of LPS, the mice doesn't have a DIC. And we spent a lot of time, finished a lot of experiments, in vitro experiments, to prove the hypothesis. As I mentioned, the tissue effect is very important, coagulation and the DIC. But how does it activate? Now we show once the LPS inside the cell by HMGB1, maybe the caspase-11, the cleaved gastromin D, the gastromin D form a pore. This nanopore can cause a calcium influx, and this creates currents that can activate a special scramblase, a lipid scramblase, and this scramblase will, you will flip the PS into the outside of the cytoplasma membrane, Once this step is finished, the tissue factor can be activated, can bind the factor 7 and activates factor 10. This is how they create, they initiate the coagulation signaling. The next step, we want to ask the upstream signal for the HMG1 release and the caspase-11 activation. And back in the 2012 and 14, Kevin and I published two papers. One is found that the type 1 interference very important, mediate HMG1 release. So now we generate the hypothesis maybe the type 1 interference signaling is very important for HMG1 release and even DIC. And we prove this is true during the gram-negative bacterial infection. The type 1 interference is very important for HMG1 release and also for the development of DIC in septic model. And back in the human patients, we also measured biomarker of this pathway, the HMG1 caspase-11 pathway with the DIC. So we use a TAT, PI1, and DIC score. Basically, this is parameter for the coagulation, coagulopathy, DIC. And we also choose the R1 alpha and the R1 beta as the biomarker for the caspase-11 activation, good correlation. So next step, we wanna know how to design a target sepsis cause the HMG release, the caspase-11 activation, and then form the DIC, and which promotes the death, organ failure and death. So now we know the mechanism. We design a high put-through screening strategy, which one can test thousands of compounds and molecules. So we want to find which one can specific or very strongly inhibit the HMG1 caspase-11 the pathway. And we found one which is very unexpected, is a heparin. The heparin, even with a very low dose, can highly effective in inhibits the HMG1 caspase-11 activation and can provide full protection in the murine sepsis. And you can see with very low dose of heparin, we only use a 5 U per mouse. With this dose, it cannot affect coagulation very well, but the low dose of heparin can inhibit caspase-11 dependence immune response and also septic shock. This is the mechanism, how it works. The heparin have two targets, main targets. One is the HMG1, can bind HMG1, prevent the binding between HMG1 and the LPS. And also the second target is even more important. It can inhibit the heparinase. This enzyme cleaved glycolysis. So just like a coat outside our cell, once it can being cleaved by the enzyme, it can expose or the air to the outside world. The HMG1 LPS easily goes in. So with these two targets, heparin can prevent the translocation of LPS from outside into the cytosol, activate caspase-11. This is how the heparin works. We also put these thoughts into the clinical study. We performed a retrospective study. We found that the heparin treatments is associated with the better survival outcome in the septic patients. Of course, we also performed perspective the cohort study, which is ongoing. So the next question is whether other program cell death is important for the MARS and lethality in other critical illness, like a heat stroke. Why heat stroke? Because it's clinical very resemble sepsis, have a hypoinflammation, systemic inflammation, cytokine release, coagulopathy, especially coagulopathy, and with the MARS and also the high mortality, very like sepsis. So we found that program cell death is important for the development sepsis. So whether the program cell death is important for the heat stroke as well. With this hypothesis, we're going to test whether hypothermia is not directly caused MARS, but through a specialized immune response we call programmed cell death or immune cell death. So with this hypothesis, this year our group published a science paper by title is a Z DNA binding protein ZPP1 promote heat stroke induced cell death. The answer is yes. Cell death causes mods, and this cell death is caused by the hyperthermia. You can see here, just take an example. The DIC in the heat stroke is actually caused by ZPP. If you delete ZPP, you can see there's no DIC as well. So you can see there's improved survival in this model. And we also found that ZPP1 is a sensor. Once it's activated by the heat stress, it can aggregate, can induce programmed cell. It's also called necroptosis. So here I'm gonna end up my talk today, and I'm gonna thank my colleagues and my collaborators. Thank you for listening. Thank you.